Right. So the agents which are other than ether have got many advantages as far as the patient and the patient comfort is concerned. We have a picture of isoflurane with us. You can have a look at it. It's an inhalational anesthetic. The general anesthesia has got the components inhalational anesthetics, that's volatile liquids, halothane, enflurane, isoflurane, desflurane, sevoflurane, and diethyl ether, and the gases in the form of nitrous oxide. So what we did was, we understood about diethyl ether and we understood what's the major difference between diethyl ether and the newer general anesthetics. The newer general anesthetics include halothane, enflurane, isoflurane, desflurane, and sevoflurane. And I am fond of making tables so that instead of telling you 4 or 5 slides on each individual agent and then later getting messed up, it's better to put all of them together, have a bird's view, and have a look at this particular slide to compare the 3 drugs in the form of a table: halothane, enflurane, and isoflurane. So let's concentrate on the slide. Halothane is the first column, enflurane is the second column, and isoflurane is in the third column. I'm going to say each and every point so that you can understand, and I'll also put my cursor with it. Look at halothane. Halothane requires a special apparatus, requires more expertise, requires more cost. The same thing is true for enflurane, special apparatus, expertise, and cost, and isoflurane, special apparatus, expertise, and cost. So I've made red color to this because you need to remember that this is not like diethyl ether, which could be used very easily. The next point is halothane, enflurane, isoflurane, all of them produce bronchodilation, bronchodilation, bronchodilation. So this is good. Next point, all of them are volatile liquids, volatile liquid, volatile liquid, volatile liquid. As far as the potency is concerned, we already discussed the minimal alveolar concentration, and you can have a look at the values. Halothane 0.75, enflurane 1.7, and isoflurane 1.4. So all of them are potent general anesthetics. As far as the coefficient is concerned, what is this coefficient? It's a blood gas partition coefficient. For halothane, it's 2.3. For enflurane, it's 1.8. And for isoflurane, it's 1.4. Not just mugging up the values, but we need to put them into the application. The value of 2.3 tells you that the rapid and medium induction and recovery is going to be there. 1.8 also means a rapid to medium induction and recovery. And for isoflurane, it's 1.4, so it's less. It means the induction is going to be very rapid. The next important point as compared to ether is all the 3 agents are non-irritant and non-inflammable. We go to the next slide to continue this particular table. With halothane, it's quick, pleasant recovery. With enflurane, quick, pleasant recovery. And with isoflurane, quick and pleasant recovery. With all the 3 agents, the incidence of post-operative nausea and vomiting is quite less. So there's less post-op nausea, vomiting for all the 3 agents. As far as analgesia is concerned, the analgesia is comparatively poor with halothane. It's medium with enflurane, and it's also medium with isoflurane. Let's think of muscle relaxation. We already said ether had a curative mimetic effect. Halothane does not have this curative mimetic effect, but it doesn't produce a very good muscle relaxation. It's poor muscle relaxation. But enflurane has got a cure-like effect, and it's quite significant, so that's good. Your skeletal muscle relaxation work is going to be done by enflurane itself. So I have made 3 plus signs to indicate that there's a significant cure-like action of the skeletal muscle relaxation. Isoflurane is also good, but it's 2 plus, and there's a good skeletal muscle relaxation with isoflurane. Now our table is taking us to the adverse effects of halothane, enflurane, isoflurane. I hope you remember they liberate the fluorine and the bromide, and this is going to be the reason for their toxicity. Most importantly, halothane produces hepatitis in 1:10,000 patients. This is a known adverse effect with halothane. You call it halothane hepatitis if the patient gets more frequently exposed to halothane. If you go to enflurane, it's much less, and with isoflurane, it's very rare. That is 1 in 500,000 patients are likely to get hepatitis. Going to the next part of the table, main important adverse effect of halothane is malignant hyperthermia. This malignant hyperthermia happens based on a pharmacogenetic factor, and due to the abnormal ryanodine receptor, you would get malignant hyperthermia. The drug of choice to treat this is dantrolene. I hope you remember your skeletal muscle relaxants. It's a directly acting skeletal muscle relaxant. With enflurane, isoflurane, there are less chances of malignant hypothermia. Going to the next point, enflurane is known to precipitate clonic seizures. It's known to decrease the seizure threshold, and this is why you get clonic seizures. There are question marks due to this particular property whether we could use this drug in epilepsy. No, it's going to be dangerous if your patient is a non-patient of epilepsy. It's also going to worsen the condition if the patient already has got raised intracranial tension, ICT, intracranial tension. But if you put isoflurane in front of enflurane, isoflurane is much better. It doesn't precipitate any seizures, it doesn't lead to increased intracranial tension, and this is why isoflurane is a preferred general anesthetic if the patient is to go for a neurosurgery or if the patient is a non-patient with epilepsy. Going to the next column, one of the important adverse effects, known adverse effects of halothane is precipitation of cardiac arrhythmias. And this cardiac arrhythmia have shown 3+ sign with red color, making you remember that arrhythmia is a very important adverse effect of halothane. And this happens because halothane sensitizes the myocardium to the action of catecholamines. With enflurane, the chance of arrhythmia are less, and with isoflurane, they are almost nil. Going to the next row, only for enflurane, it's written C/I, that's contraindication. Enflurane is absolutely contraindicated if the patient suffers from renal damage. That's an important contraindication for enflurane. Going to the next row, for isoflurane only, I have written vasodilation. Yes, it produces vasodilation. It maintains the coronary blood flow, and this is why this particular general anesthetic is the anesthetic of choice if the patient is suffering from ischemic heart diseases. That's IHD. So I hope this particular table is going to be very useful to you to compare all the three drugs in a bird's view. Next we go to the two drugs, the newer agents, the desflurane and sevoflurane. Let's go to the slide. Both of them are newer and expensive agents. Both of them are very potent. For desflurane, the AMS is 6.5, and for sevoflurane, it's 2. For desflurane, the blood gas partition coefficient is 0.42, which tells there's a very rapid and smooth induction, which takes about 5 minutes. With sevoflurane 2, the blood gas partition coefficient is 0.69, it's quite good, and there's rapid and smooth induction within a period of 5 minutes. Desflurane supersedes sevoflurane as far as the tissue toxicity is concerned. With desflurane, the tissue toxicity is minimal, but sevoflurane is known to be a nephrotoxic agent, so you need to take care as far as the kidney functions of the patient is concerned. With desflurane, it has a disadvantage. It's got a very pungent odor. It can lead to cough, it can lead to laryngeal irritation, and it can lead to laryngospasm. Whereas as far as sevoflurane is concerned, it's non-pungent. Not only that, it's non-pungent, but it's pleasant and there's no irritation. Just like pungent odor, cough, laryngospasm, and laryngeal irritation, desflurane also leads to sympathetic stimulation, whereas sevoflurane doesn't have a property to produce sympathetic stimulation. Both of them, they produce pleasant, smooth, and rapid recovery. And this is why these two agents are the agents, general anesthetic agents of modern medicine. With desflurane, a very important thing is it produces very less disorientation and least cognitive motor impairment, so that you can carry out a small procedure in the outpatient department and the patient can reach home, the patient can get out of your hospital quite early. So least disorientation and least cognitive motor impairment, and that's why desflurane is preferred for outpatient surgical procedures. Whereas sevoflurane is concerned, the important part about sevoflurane is it's very pleasant anesthetic to inhale. It doesn't produce any irritation, no laryngospasm, no pungent odor, and this is why sevoflurane is preferred when it comes to the carrying out procedures, especially in children. As far as the other general anesthetics are concerned, we are left with one substance, and that's nitrous oxide. That's called your laughing gas. This is an inorganic inert gas with the MAC value of more than 100%, so it's a less potent general anesthetic. You can't rely on nitrous oxide as a sole agent for major procedures. But the blood gas partition coefficient is just 0.47, leading to rapid induction and recovery. So nitrous oxide will be preferred for induction of anesthesia. It could also be used for dental outpatient department procedures as a sole anesthetic. 80% of nitrous oxide could be combined with 20% of oxygen. Nitrous oxide is a good analgesic. The muscle relaxation is comparatively poor, and it's a safe general anesthetic as far as cardiovascular system, respiratory system, liver, and kidneys are concerned. It's supposed to be the least hepatotoxic general anesthetic agent. Nitrous oxide produces two typical effects. Number one on the slide is diffusion hypoxia. What's the diffusion hypoxia? It produces less oxygen uptake during recovery. You need to remember about this. This diffusion hypoxia is a negative point about nitrous oxide. What is the other effect? The other effect is a good effect, and it's called second gas effect. Nitrous oxide has a very fast uptake from the alveolar gas, and this is why it helps to concentrate the other halogenated anesthetics, the other anesthetic agents in the alveoli. Because the nitrous oxide is taken up fast from the alveolar gas, the other halogenated general anesthetics get a chance to get concentrated, and this is good, and this is called second gas effect. What are the adverse effects of nitrous oxide? It could produce postoperative nausea and vomiting. It is a phytotoxic agent, and it could produce bone marrow suppression. It also replaces nitrogen in various air spaces, and when nitrogen is replaced by nitrous oxide, you get increase in the volume of the closed spaces, and this can lead to pneumothorax. So these are some of the adverse effects of nitrous oxide. So we were talking about inhalational anesthetics. Now let's go to the intravenous anesthetics. As we already classified, the fast-acting agents are used for induction and short procedures, and they have a rapid distribution across the blood-brain barrier, and they also have a rapid redistribution. Try to remember your general pharmacology module regarding rapid redistribution. And I gave you an example of thiopental sodium at that time, which is an ultra-short-acting barbiturate. It starts the effect very fast and completes the effect very fast because it gets out of the brain very fast. And that's called rapid redistribution. The second agent is a non-barbiturate, that's propofol, and along with it there's etomidate, and these agents also have rapid distribution as well as redistribution. There are some slower acting agents like diazepam, lorazepam, and midazolam. And don't forget the conscious sedation with midazolam. So now we are into the discussion of the intravenous anesthetics. Have a look at the slide. There is thiopentone in the extreme left column. In the middle column there is propofol, and the last column is etomidate. I hope you remember thiopentone is an ultra-short-acting barbiturate. Please consider on the slide that I am showing you. Thiopentone is an ultra-short-acting barbiturate. Propofol and etomidate are non-barbiturates. All of them have got a very rapid induction. For thiopentone is 15 to 20 seconds. For propofol 15 to 45 seconds. And etomidate extremely rapid, that's 5 to 10 seconds. A recovery from anesthesia is good. For thiopentone is 15 to 20 minutes for complete recovery. With propofol 3 to 15 minutes and etomidate 5 to 10 minutes. Thiopentone is a poor analgesic and weak skeletal muscle relaxant, and propofol has got an advantage over it. It's a very good analgesic, whereas etomidate does not produce satisfactory analgesia. Thiopentone is preferred for induction of anesthesia and for short procedures because the duration of action is going to be short. Propofol is used for induction, and sometimes it could also be used for maintenance. And etomidate is used only for induction and only for short periods. I am saying it with highlight, is used only for procedures which are going to last short. I am going to come to it once again. The next point is thiopentone disorientation may last for many hours after the procedure, and that's what we experience when thiopentone is used. Whereas with propofol, the recovery is extremely rapid, and with etomidate too, there is rapid recovery. Thiopentone is also useful to treat convulsions, and is also used to facilitate the verbal communication. Propofol is more preferred in the setup when you want to use it in intensive care units for a prolonged sedation in some patients, in critical patients. Etomidate is not used for long procedures, and I have underlined it and I have made it red. We're going to come to know the reason of this on the next slide. The next slide is telling about the adverse effects. Thiopentone produces a lot of post-operative nausea, vomiting, cough. It suppresses the myocardium. It decreases the blood pressure. Propofol has less post-operative nausea, vomiting, but it could produce hypertension. And as far as hypertension is concerned, etomidate least hypertension, but it does produce post-operative nausea and vomiting. All the three agents are irritants and they produce irritation. Thiopentone, irritation on extravasation. Propofol, irritation on intravenous administration. And etomidate also produces irritation and pain on injection. Coming to the other adverse effects, thiopentone leads to shivering, apnea and laryngospasm, and it cannot be mixed with succinylcholine, this SCH succinylcholine, because they are not compatible with each other when mixed in a syringe or infusion. And thiopentone, being a barbiturate, is contraindicated, CI contraindicated in acute intermittent porphyria. Propofol is known to produce bradycardia, excitement and involuntary movements, whereas etomidate is known to produce myoclonic movement and rigidity. And here comes the next point. It decreases the cortisol level and it decreases the aldosterone level. That's very important. And because it decreases all these levels of cortisol and aldosterone, it could be very critical if the procedure is going to last for a long time. And this is why I was saying 2 times, etomidate should not be used for long procedures. It's quite dangerous to have low cortisol levels and low aldosterone levels for a long period of time. So etomidate should be preferred only for short procedures. Etomidate is contraindicated in pregnancy. Let's have a look at the good points. Thiopentone doesn't decrease the cerebral blood flow. It doesn't increase the intracranial pressure. So it could be preferred for neurosurgery or the surgery which is due to the head trauma or brain tumors. Propofol has got extremely good recovery and a very rapid recovery with least disorientation. That's why it is a preferred agent for OPD and ambulatory surgical procedures as well as for spinal tumors. And etomidate, having less cardiovascular effects, it is supposed to be a safe anesthetic in cardiovascular conditions like coronary artery disease and in shock. Let's go now to the benzodiazepines, which are used for sedation for short procedures, sedation before general anesthesia, various procedures like endoscopies, angiographies, catheterization, etc. Midazolam is an agent which is more potent than diazepam and doesn't produce local irritation. Lorazepam and diazepam, these agents are also used for this purpose. And benzodiazepines produce respiratory depression and anterograde amnesia, which lasts for at least 2 hours. Conscious sedation is a very important use of benzodiazepines. I take you to conscious sedation on the next slide. What is conscious sedation? This is used for diagnostic and short procedures and dental procedures under local anesthesia in place of general anesthesia. The patient was supposed to go into the general anesthesia, but I'm trying to avoid general anesthesia. I can do conscious sedation, especially when the patient is apprehensive, especially in medically compromised patients or the patients with altered level of consciousness, or to decrease the physical and mental stress of the patient. The advantage is the patient can cooperate and there is no great risk to the cardiovascular or respiratory system. At the end, we come to the special types of anesthesia. The first one is dissociative anesthesia produced by ketamine, which is practiced for short procedure lasting 30 to 40 minutes. The advantage is the patient appears conscious. So I'm not putting it classically in the general anesthetic agents. I'm calling it a special type of anesthesia. The second one is neuroleptic analgesia with droperidol and fentanyl. Let's come to dissociative anesthesia. What is dissociative? A sense of dissociation from surroundings. A great feeling. Someone is coming to you, someone is taking a cut on your hand, but you feel that it's not my body, it's someone else's body. A great feeling. There's a sense of dissociation from the surroundings. The patient remains calm and quiet, and the patient doesn't feel anxiety about what's happening to him. The patient is in light sleep or sedation. There is amnesia, there is analgesia, there is catatonia or immobility, and the duration lasts for about 30 to 40 minutes. This dissociative anesthesia is done mainly in children and young adults for diagnostic procedures of short duration so that the patient can remain immobile, the patient will have the lack of pain, the patient is going to forget the perioperative events, and the patient will be in light sleep and sedation with a sense of dissociation. Short procedures like burn dressings and the CT scan can be performed. Patient remains conscious, can cooperate, and there is less cardiovascular and respiratory system or less risk which is present with the general anesthetic agents. Ketamine is a phencyclidine derivative, that's the PCP derivative. As a glutamate antagonist, it blocks the NMDA receptor, and most importantly, ketamine can raise the blood pressure and the heart rate. This is good or bad? This is good and this is bad too. It's good in a situation when the patient is already suffering from hypertension, hypovolemia and shock. Raising of the blood pressure is good. It also increases the intracranial tension. And the last important adverse effect is precipitation of unpleasant dreams and emergence delirium. You need to know this word, emergence delirium. That's excitement and hallucinations and increased psychomotor activity. This happens because ketamine has got a hallucinogen-like effect or the PCP-like effect. It's contraindicated in psychiatric disorders, cerebrovascular disease history, hypertension and stroke. Just now we said it raises the blood pressure. So if your patient is already suffering from hypertension, this is a contraindication. The next anesthesia, the special type of anesthesia, is neuroleptic analgesia. It's produced with a neuroleptic agent droperidol and opioid analgesic fentanyl. It appears similar to the dissociative anesthesia because it lasts for 30 to 40 minutes and you carry out diagnostic and minor surgical procedures lasting for short duration. Patient has immobility, analgesia, calming and amnesia. Neuroleptic analgesia can decrease the heart rate and the blood pressure and can suppress the respiratory system, produce confusion and mental depression and extrapyramidal symptoms. Sometimes it could be combined with 65% of nitrous oxide, then you start calling it neuroleptic anesthesia. You need to remember 3H for halothane, adverse effects of halothane. First H is hepatitis, the second H is hyperthermia H, that's for malignant hyperthermia, and the third H for heart because halothane produces arrhythmias, the cardiac arrhythmias, by sensitizing the myocardium to the action of the catecholamines. There are skeletal muscle relaxants, as we mentioned, are required in the balanced anesthesia. They are administered to facilitate the intubation. You can use succinylcholine, and they are required to suppress the muscle tone to the degree required for surgery, and you can use neuromuscular blockers for this. Before giving anesthesia, we need to give some medication to the patient, and that's called pre-anesthetic medication. The purpose is to make the anesthesia smooth and for uncomplicated peri-anesthetic course. These are the two important reasons why we give pre-anesthetic medication. Various drugs could be given. Number one is anticholinergic drugs in the form of glycopyrrolate, which is a newer atropine substitute with rapid and long action and less tachycardia and no central effects. Otherwise, you have atropine and scopolamine. All these drugs are anticholinergics. They prevent the bradycardia and cardiac stoppage. They decrease the secretions. They relax the smooth muscle. And they prevent the cough, vomiting, laryngospasm. And they do also decrease the gastric secretion, gastric hydrochloric acid secretion. Anticholinergics is the mainstay of pre-anesthetic medication. In the next order, you have opioids. They are going to produce analgesia, sedation, and amnesia. And you have drugs like fentanyl, sufentanil, alfentanil, the newer derivatives of fentanyl. You could also think of using morphine, pethidine, and pentazocine. So all the opioids for analgesia, sedation, and amnesia. Most importantly, there are benzodiazepines, very commonly used as pre-anesthetic medication for sedation, anti-anxiety effect, decreasing the apprehension, and for producing amnesia. You have diazepam, lorazepam, and midazolam. Phenothiazines are the antiemetic agents, but they produce a good sedative effect, and there's a very prominent agent in this group is called promethazine as well as hydroxyzine, extremely useful to prevent the perioperative vomiting. Lastly, you have antiemetic agents which decrease the gastric hydrochloric acid, decrease the reflux, and prevent the aspiration. You have ondansetron, domperidone, metoclopramide, cisapride, and the H2 blockers in the form of ranitidine and famotidine. You need to take care of the pre-anesthetic medication just as the general anesthetic agents. I hope it was an extensive module, but it's going to be very important to you. Make a good use of this, and my good wishes are always with you. Thank you so much.